Hello, today we're going to be doing our chapters 23 and 24. This is a combined PowerPoint presentation, and I would like you to spend just a minute looking over your course content outline to make sure that you're studying the material that you need to. There's a lot of information about premature babies that is beyond the scope of what we're going to be talking about. You may talk about some of this as you move into pediatrics, but just pay attention to the few things that we are going to be covering here in OB. So fetal growth, there's lots of things that can actually affect fetal growth. And so the few things that we're going to touch on here is maternal nutrition. I mentioned this before in other lectures that maternal nutrition, if someone is eating Cheetos and Pop-Tarts, that's what they're going to make their baby out of. So it is true that the body will give all the prime nutrients in the mother's body to the fetus and deprive the mother. But if the mother doesn't have enough nutrition for herself, then of course the baby's not going to have enough nutrition. Genetics, sometimes women grow large babies because that's in their genes. Different groups of people, different ethnicities sometimes have larger babies, and that's just by design. So it's not always an issue with diabetes, which we're going to be talking about here in a minute. And then placental function. Sometimes our babies don't get enough of what they need because of placental function or how the cord is inserted into the placenta. And then environmental factors certainly play a part. Pesticides and exposures to toxins and exposures to other things are teratogens that are going to affect the genetics of our baby can affect our growth. One big thing that we've seen in the recent months is Zika virus that definitely affects the growth of the fetus. So there are birth weight variations, and I just want to touch on this here. We have appropriate birth weight. We have small for gestational age. That's typically under 2,500 grams or 5 pounds, 8 ounces. Large for gestational age is anything over 4,000 grams or 8 pounds, 13 ounces. And any large for gestational age baby is we're going to look a little further to make sure that they didn't have, the mom didn't have some undiagnosed diabetes. So here's a picture of a small for gestational age and a large for gestational age. And you can see there's quite a variation between these two babies. We also have some distinction in our birth weights. We have our low birth weight baby, which is any baby under 5.5 pounds. Our very low birth weight baby, which is 3 pounds, 5 ounces, under 3 pounds, 5 ounces, and our extremely low birth weight baby, which is under 1,000 grams or 2 pounds. And so here is a picture of some extreme differences in birth weight. So here, I think this is low birth weight. No, this is very low birth weight, and average for gestational age. So some of the small for gestational age issues that we see, and it's not just our premature babies that have this issue, is these are our smaller babies. So we have, every facility has their own policy, but we have restrictions on how much the baby has to weigh before they can go home, or if they are under a certain weight or under a certain gestational age, they automatically go to the NICU for admission because we know that there are going to be issues that will need to be dealt with. So things that we see, perinatal asphyxia, babies that don't do as well during delivery. They can't maintain their temperatures. They can't maintain their blood sugar. So they have hypoglycemia, which can be detrimental. It can even cause death because the brain cannot be without sugar for any amount of time. They have polycythemia. So then if they have more red blood cells, then they have a higher risk of hyperbilirubinemia. And we also see more meconium aspiration. And spend some time in your book looking at the table 23.1. It talks about the different birth traumas that are there, especially to the head, that we see in our small for gestational age babies. They just don't have the same strength in their skull as our average weight babies. So we do have some bleeding issues and some other concerns. So spend some time looking at that. And then our large for gestational age baby also has issues. We have maternal diabetes. We're concerned if we have a baby that is, like I said, over 4,000 grams or over 9 pounds, depending on your facility. We are going to be looking for additional things. We're going to be checking blood sugars, which we wouldn't do unless there was a reason to on a baby. And then, but because of the weight, we are going to be looking at blood sugars. And then we're also going to be looking at hematocrit because we know that our large for gestational age babies or babies that have been exposed to high blood sugars in the uterus are going to have larger amounts of red blood cells. And if they do, then they're at higher risk for bili. And we're going to talk about hyperbilirubinemia in a minute. So if the mom has had a history of a macrosomic infant, macrosomia is large for gestational age. If they're post-dates, they're at risk for being large for gestational age. If the mom is obese, the baby is higher risk for being large for gestational age. Males are larger. And then sometimes, like I said, just genetics. Sometimes people will have large babies, and that's just by design. And then multiparity, if women have had babies before, sometimes they grow each baby just a little bit bigger. So some of the characteristics of a large for gestational age baby is that plump, full face, proportional increase in body size. They have very poor motor skills because they have so much fat, and that fat layer is so large that they do not have the motor skills, especially for breathing and sucking. And those are the motor skills that are super important as a newborn. And so we see these very large babies that cannot eat because they just don't have the motor skills to do it. And then they have difficulty regulating their behavioral states. They're very sleepy. They can't seem to stay awake or alert, and we have issues. There have been lots of pictures in the recent months of these very large for gestational age babies, and I think it kind of made the social media rounds, and everyone started talking about how cute they were. And the reality is, this baby is in a lot of trouble. This baby is in the NICU because it cannot eat, it cannot maintain its blood sugar, sometimes it cannot breathe, and it's going to be in the NICU for a large amount of time. So there is nothing cute about a baby, and I assume, I shouldn't always assume, but I assume this baby was from uncontrolled diabetes and uncontrolled blood sugar in the mother. And that's what we see the majority of these sick, large for gestational age babies. And you can see this baby needs respiratory support, feeding support. He's on monitors. He has an IV for his blood sugar. This is something that could be prevented with good prenatal care and good compliance on the part of the mom. So as I mentioned, there are issues with your large for gestational age baby as well, birth trauma. These babies don't fit through the pelvis as well. We see a lot more shoulder injuries and shoulder dystocias. I already talked about hypoglycemia and polycythemia, which moves into our hyperbili. So bilirubin, and we've talked about this before, but and I'll mention it multiple times, is the breakdown of excess red blood cells. The byproduct of that is bilirubin, and as the bilirubin rises in the bloodstream, it can be toxic because the baby's not able to excrete it as fast as it needs. So it's a normal process. We see this process happen in our newborns, but if we have excess red blood cells, we're going to have excess bilirubin, and then we're at a higher level, a higher potential for having issues with jaundice. So when we're talking about our term babies, we're going to consider our term baby, and this is from your book, born 38 weeks and above. Preterm is born before the completion of the 37th week. This is gestational age. Late preterm is 34 to 36 weeks and 6 days, and postterm is anything after 42 weeks. There's some variations in what we consider preterm and postterm and late preterm, depending on the source that you look at, but for testing purposes, this is what we would utilize. So our postterm newborn, the placenta starts to degrade. It isn't working as well. It's not providing the adequate oxygen and nutrients to the fetus. And so really, we see a remarkable increase in fetal demise in babies that are after 41 weeks and 3 days gestation. So because inductions of labor take several days, you typically will start to see inductions happening at a earlier age. So most doctors are trying to get their patients in before that 41 week in order to get the induction process started so that the baby is born before that time frame. We see dry, cracked, wrinkled skin, sometimes meconium stained, and that's because that vernix has gone away. Sometimes they will have long, thin extremities because that's where the nutrients are pulled from the extremities so that they go to the core of the body. They usually have abundant hair on their heads and a very thin umbilical cord. And like I said, reduced vernix and lanugo. So here's some pictures. There's that dry, cracked skin. This is what the vernix was keeping from happening. You can see it happens all over the body. So we just want to moisturize and make sure that we get that nice and softened up because that can be a potential for infection. This baby actually has some meconium staining. You can see that yellowing of the skin. So they also have issues with perinatal asphyxia, injury during birth, hypoglycemia, hypothermia. They aren't able to maintain their temperatures because they're not able to keep themselves regulated. We see meconium aspiration in these babies because there's more chance of meconium being released. And so we have to be on the lookout for the respiratory issues that come along with meconium aspiration. So jumping back over to preterm, what are some of the things that cause babies to be born early? Now, we're not talking about small for gestational age, that they weren't appropriate age and just small for their age. These are babies that are actually born at an earlier gestational age. Infection is the #1 reason for preterm labor. Maternal or fetal distress, something's going on with the placenta, sometimes blood pressure issues in the mother can cause preterm delivery. Bleeding, we see, again, placental issues, placenta previa, placental abruption cause preterm delivery. And then that stretching of that uterus again, if there have been any prior surgeries, sometimes a history of therapeutic abortions where the cervix has been dilated frequently, that can encourage preterm labor and preterm delivery. Some of the characteristics here you might see are less than 5.5 pounds. They have poor muscle tone. They don't have a lot of fat, so they can't control their body temperature. They have a very poorly formed ear pinea. Sometimes if they're very premature, their eyelids are still fused. The skull is soft and spongy. They have absent to few creases in their soles, very thin, transparent skin, and abundant vernix. So if you have a baby that is born with a ton of vernix, that cheesy substance, the first thing you're going to be watching is respiratory. Because if you have a baby with a ton of vernix, they may be earlier than anticipated, and then they may not breathe well because they don't have the surfactant development. Here are some pictures of our premature babies. When they are born early, they have to come into the NICU, and we have to pretty much do all those things. We have to support their temperature, their skin, their environment, their feedings, their respiratory. We have to do everything for them. And so with that type of care in the NICU, and you all are going to get to experience a NICU day, you will see that we basically put them in a womb-like environment and don't stimulate them and let them continue growing and resting and healing while we're supporting their systems. Here is a little guy that you can see, this is a startle reflex, but this little one is probably, they're moving to another bed or letting the mom hold or something. We don't spend a lot of time holding these premature babies. We have to teach the parents that these are not term babies. They're not ready to be cuddled and held. We touch them during their scheduled touch times, and then we have to leave them alone so that they can rest and mature. They're not neurologically mature enough to respond as a term baby would. Some of our preterm problems, a lot of the same things that we see in our small for gestational age babies and large for gestational age babies: hypothermia, not being able to maintain their temperature; hypoglycemia, so that's why we will have to support their feedings. They don't have enough of a suck response. They can't make enough of a milk transfer to be able to take in the nutrients that they need. So we tube feed them and usually support them with IV fluids as well. And again, hyperbiliary, their livers are even more immature, and they have all this excess red blood cell breakdown that increases their bilirubin. So our management, the things that we're going to do to help these babies, we're going to help with thermal regulation, obviously oxygenation. We're going to decrease that stimulation. We definitely want to watch for infection. This is why the NICUs are so strict about washing all the way up to the elbows for 3 minutes, picking underneath each fingernail and scrubbing underneath each fingernail, and not having fingernails past the end of the finger, because this will bring bacteria into these babies. They're also very strict about the visitors that come in to the NICU environment, because this is ICU for the most vulnerable patient. We also will do pain management, growth and development. We want to make sure that we're positioning and encouraging their growth and development, and helping these parents come to terms with having a premature baby and the different needs and things that they're going to have to deal with as they take this baby home and help it gain its full potential. Our late preterm babies sometimes we'll see out on the floor, but they are not term babies, and we need to not treat them as term babies. So some of the big things we see are inadequate feeding. As a lactation consultant, I'm constantly working with our 36, 37-week babies, because they look like they're on the breast and doing everything they're supposed to be doing, but they don't have the muscles and the fat pads to create the suction to pull the milk out of the breast. So even though they look like they're doing everything well, they're not getting milk transfer. And so that's one of the things that we're on the lookout very heavily with our late preterm is, are they actually feeding well? And one of the ways that we know they're feeding well is we're looking at their diaper count. We're looking at their weight loss and paying very close attention to those things to make sure that we don't miss a baby that looks like they're feeding well when they're actually not. So now moving into chapter 24, I'm just going to hit a few of these topics in this chapter as well. When you're talking about acquired disorder versus congenital disorder, acquired are things that occur soon after birth or at birth. They're problems that the baby wasn't born with them, in that no matter what the experience was, they were going to be there. It was something that happened at birth. So there's usually no identifiable cause. Sometimes it's conditions that happen during the pregnancy, like for instance, exposure to some sort of chemical or infection or disease, Zika, cytomegalovirus, rubella. These are all things that we can see. Syphilis, GBS, all of those are acquired disorders. Congenital disorders are usually some sort of malformation or something that happened during development, and it is a problem with inheritance. So those, they can be very complex and have lots of different factors that go along with that baby. So here are some acquired conditions of the newborn. Neonatal asphyxia, that's not getting enough oxygen during delivery. Transient tachypnea, that is tachypnea that comes and goes after the baby is born, and it's related to respiratory distress. You have respiratory distress syndrome. Meconium aspiration, that's breathing in some of that stool that's released that can cause some serious lung issues. Persistent pulmonary hypertension and bronchopulmonary dysplasia go along with that meconium aspiration. They're progressions of that disease process. Retinopathy of prematurity is the underdevelopment of the eye, and it is caused from the oxygen that we actually give the babies to help them survive. Interventricular hemorrhage. Again, this is things that happen to our premature babies during delivery sometimes. Necrotizing enterocolitis. It's a gut issue that happens to our premature babies that are not ready to receive feedings, but we have to feed them to keep them alive. We have infants of diabetic mothers, and we know the issues that go along with that. Hypoglycemia, not having good muscle tone, not having good respiratory tone. There's birth trauma that can happen. We're going to talk about a few of those. There's substance abuse, and our babies are born addicted as well. We've talked about hyperbilirubinemia and newborn infections. So there's lots of things that can happen to our newborns that are acquired conditions. We're just going to hit on a few of those. Respiratory distress syndrome is typically because there's a lung immaturity and not enough of our alveolar surfactant. Surfactant is that soapy substance that keeps the alveoli open that allows gas exchange to happen. This doesn't become completely developed until somewhere between 28 and 32 weeks. And we don't know exactly what day they have their full surfactant development, but they don't breathe well until they have that. So some of our signs and symptoms of that would be grunting. That's where the baby is making the sound. Instead of breathing normally, you hear a where they're working really hard, using all of their chest muscles to try to get in enough air. Nasal flaring, those nares flaring in and out. Retractions of the baby's chest wall. Central cyanosis. It's never normal for a baby to be blue around the lips or the mouth. Heart rate above 150, and then crackles and tachypnea, more than a rate of 60. So respiratory distress syndrome is very common in our premature babies. Sometimes we even see it in our term babies. This is one of the things that as nurses we are assessing for every time we're doing vital signs. We're looking to make sure that we do not have any respiratory signs that tells us that they're in distress. Here are some of the things that we can do to support our respiratory distress syndrome. Sometimes we use a CPAP, sometimes we use a high flow nasal cannula, sometimes we have to do an intubation. So just like with an adult, if we have respiratory distress, we're going to have to intervene. Our babies do not have the reserves that our older children and adults have. So if we have respiratory distress, we're going to have to intervene very quickly so they don't get tired and stop breathing on us. Birth trauma are injuries that are related to the actual birth process. We see fractures, we see shoulder injuries. I'm going to talk about those in a minute. Head trauma, cephalohematomas. Risk factors are very large babies. We see sometimes lots of issues with these very large babies trying to fit through that space. Sometimes the risk factor is mom has a history of a previous traumatic delivery. Maybe she has a very small pelvis and it's difficult to fit any size baby through there. And then, of course, whenever we have interventions like a vacuum or forceps or even as much as an internal fetal monitor, those can all potentially cause birth injury. And of course, the biggest one that we're worried about birth injury is asphyxia, not getting enough oxygen. And that's our job as a nurse to make sure that we are watching for those types of things. So the next slide here is looking at a shoulder dystocia injury. So this is a shoulder dystocia, again, is where the shoulders are not fitting through this pelvis. And what happens if we have a baby where the head has been born and the shoulders are not fitting, sometimes we'll have an injury to the shoulder, to the brachial plexus, or the nerve that is there. It can become damaged from the tugging and pulling, and then they have a lifelong injury. It cannot be repaired. So the next picture is a little rough, but these are people that have had birth injuries. So here you can see this was a shoulder dystocia, and this baby is showing signs that nerve has been stretched and pulled beyond repair, and this will probably never heal. This is what it looks like in an adult that had a brachial plexus injury, and you can see he's had multiple surgeries trying to fix that because you can see the scar there. And so again, Erb's palsy or brachial plexus injury is when you see an injury because of a shoulder dystocia, a baby that did not fit through the pelvis. So it can be pretty severe. So our nursing management, when we have any sort of birth trauma, is supportive. Obviously, we're going to be assessing for signs of complication, and we just make a very objective documentation of what it is that we see. Baby moving both arms, baby not moving left arm with stimulation. These are the types of things that we are just going to document, because most likely this is going to go to litigation. We want to support and educate the mom, making sure that we give them any community referrals and realistic appraisal of the situation. There's no need to hide anything. We never want to accept blame, but we do want to talk about it. It looks like, you know, the baby's not moving the arm, and of course the pediatrician is going to discuss this with the mom, but we just want to be as honest as we can, because we're here to support the family and provide education. So I'm going to talk just a little bit about bilirubin again. I know we've talked about it a lot, but there's two types of jaundice. Physiologic jaundice happens on the 3rd to 4th day of life. It peaks about the 3rd to 4th day. This is, there's really two classifications of physiologic jaundice. And again, this is an imbalance. So we have all these red blood cells that need to be broken down. The byproduct of breaking down those red blood cells is bilirubin. High bilirubin levels in the blood are what we call jaundice, and that can be toxic to the brain. So with our physiologic jaundice, it peaks about the 3rd or 4th day of life as the baby starts to take in more fluid and excrete more bilirubin. They poop it out. That's how they get it out of their body. That balance happens. So sometimes what we see is not enough breast milk jaundice. Not enough breast milk jaundice is the baby's just not getting enough to feed. And we can do a couple of things. We can hand express and get the milk out of the breast and supplement the baby with that, or we can supplement with formula. But this is just a supply issue. We need to be looking at, is the baby getting enough? And how do we know the baby's getting enough? It's based on what comes out. The other type of jaundice, on the other side of that, is pathologic jaundice. This happens within the first 24 hours of life. This is where you're going to have a baby that's been exposed to antibodies from a mom that was Rh negative, or an ABO incompatibility, a blood incompatibility. So this is serious. A pathologic jaundice that happens within the first 24 hours is going to have to be medically treated. These are the babies that are at highest risk to get connectrus, which is the brain damage that happens from too high of a jaundice level. So it is our job as the nurse to make sure that the baby's feeding well, that the baby is excreting well, because we've got to get that jaundice out. We're going to be looking at the risk level so that these parents know when they should have their next follow-up appointment. And I'm going to go over that in the next couple of slides. So our risk factors for jaundice that we're going to be looking at our nursing assessment is, are they preterm? Did they have a long, hard delivery? Is this baby a diabetic from a diabetic mother? Is this an infant born to a diabetic mother? Because they're going to have more red blood cells, then they're going to have increased bilirubin. Are they feeding well? Are they late premature, where they don't have the suck power to bring in that fluid? So we're looking at risk factors. Pitocin is a risk factor for increasing jaundice. So all of these things need to be taken into account. And then we're going to look for, are there signs of Rh incompatibility? Do we have an A, B, O in the family? Is mom A, dad's B, baby's O? That's what we call a setup, and that could cause increased jaundice. And then, of course, we're going to be watching the bilirubin levels. So one of the things that we're going to be doing is testing the bilirubin level through a sensor that is just through the skin. It's non-invasive, and graphing it on a chart. And we can look to see what risk level this baby falls into. So what are we going to do once we've assessed? We're going to be doing some nursing management. Obviously, we're going to be educating this family. Sometimes the babies are going to need some additional help in breaking down that bilirubin, so we use things like phototherapy. Phototherapy causes the bilirubin to be excreted in the urine. It makes it water soluble, so now they are able to excrete it in the urine as well as the stool, so that it increases the ability to get it out of the body. Early feedings. Frequent feedings, making sure that they're appropriate feedings. And if they're not appropriate feedings, we need to get the milk out of the breast and into the baby. So hand express or pumping, hand expression works better early on, and then spoon feeding or cup feeding what we get out to the baby. And that's how we can supplement with the mom's own breast milk. So here you see some examples of the bilirubin lights that we use. These are our phototherapy lights. So if the babies are under lights completely, they must wear a mask because their eyes are sensitive to this type of light. If they're using a Billy blanket like this, it depends on your hospital policy, but they are not always required to wear a mask. But the more time they have this on them, the quicker that bilirubin level is going to go down, because remember, this helps to change it into the water soluble variety so that they can excrete it out of their urine as well as their stool. Other risk factors. So if you see jaundice within the first 24 hours, that is pathological and needs to be the pediatrician needs to be informed right away. If a sibling had jaundice, this would be a risk factor for this baby. If there is some sort of RH incompatibility or ABO incompatibility, if they're not feeding well, and that could be either formula or breastfeeding, if there is infection, if they're an infant of a diabetic mother, or if they're immature, all of those could cause an increased chance. If they have a cephalohematoma, bruising from delivery, bruising anywhere, facial bruising, that bruising are red blood cells that are going to have to be broken down that are going to increase their chance of having issues with Billy, hyperbilly. And if they have, if their hematocrit is high, they may have issues with hyperbilly because they have all these excess red blood cells. And then certain certain groups of people have higher bilirubin levels in their blood already, so they start at a higher level. So you want to pay attention to certain ethnic groups. That's going to put them at higher risk. So here's the graph I was talking about. So whenever you're giving a bilirubin level, you must also know the age in hours of the baby. So for instance, this graph, you can see it peaks at about 3 days. This is when those zones really peak, and then they should even out. So here, these are your hours old, and this is your jaundice level. So whether you're doing the transcutaneous Billy or a blood level, you would have to know the number, your serum or your transcutaneous, that would be your number. So let's say in the first 24 hours, your baby is 10. So here you go to 24 hours, and then you go to 10. So right now, that baby is in the high intermediate risk zone. And what that means is we know that this is not going to peak until about the 3rd day. So if you look over here on the 3rd day, 72 hours, if it were 10 on the 3rd day, nobody's concerned about that. But because it's so high early on, we know that it's still going to continue to climb, and we have the potential of getting into that high risk zone. So each one of these risk zones tell us what kind of interventions we need to do. Low risk zone, we don't need any interventions. Low intermediate, this baby needs to be seen typically in 24 to 48 hours. High intermediate, the baby needs to be seen within 24 hours by a pediatrician, 24 hours of discharge, to make sure that those levels are not going outside of the range. A high risk zone, that baby is going to be in the hospital. We're going to put them on Billy lights and try to bring that bilirubin level down before we send them home. And then a critical risk zone, they're going to go into the NICU and start having extreme treatment. And there's some other treatments that we can do. So when you're talking about a bilirubin level, it can't just be the blood test. It has to be in relationship to the hours old for you to be giving good SBAR information and good communication to your nurses. So this is bilirubin, and we will talk more about that when we talk about the normal newborn. And then here for infections, this is the other big issue we see with our newborns, is babies do not have an immune system other than what they've gotten from their mothers. So if mom has a very healthy immune system and her labor and delivery has been kept very nice and clean, and she hasn't had a lot of exposure to things, then we have lots of less risk of infection in the newborn. But our babies can be infected with fungal, bacterial, or other microorganisms. We have 3 different classifications. We have congenital, meaning the baby got sick while it was still on the inside. Early onset is in that perinatal period, and then late onset is after the baby has gone home. So there's lots of things that can cause infection. Rupture of membranes for more than 24 hours. We see higher rates of infection. That's why we start some prophylactic antibiotics. GBS, Group B strep, that is that little swab that we do down below. And a mom that has Group B strep colonization, the baby has more chance of getting infected. Long labors, the baby is put under stress for a long period of time and is susceptible to infection. One of the big things we've seen recently is people eating their placentas. We see lots of late onset infection because people are eating the placenta, which is the organ that keeps the bacteria away from the baby. So when we have signs of infection, this is what we would be looking for in our baby. These are some of the things that is in our normal assessment. Decreased temperature. Babies that are septic or sick with infection are not going to have the energy to make an increased temperature. They'll have low temperatures. So this is why a baby that's not holding his temperature, it's a big sign that we maybe have an infection brewing. Poor feeding, that's another sign of infection. We will always look for a CBC to see if we have a left shift, which is all those early neutrophils being created in anticipation of fighting this infection that it senses is there. CRP, a C-reactive protein, is a test that we do that just shows inflammation. And it's not specific for infection, but in infection, you might see an increased CRP. And we use that with babies because we can't wait for a baby to be sick in order to treat it as if it is. If we wait till the baby has all the signs of infection, we're going to lose that baby. So if we have hints or ideas that a baby is getting sick, high CRP, a left shift in the CBC, a low temp, poor feeding, we're automatically going to treat this baby, because if we don't, we're going to lose this baby. And then a positive blood culture. We are going to take a blood culture to see if we can grow any sort of bacteria, but that takes 24 to 48 hours, so we do not wait for the results before we start treatment. So newborn infection is an important aspect to know in our perinatal side, and then when you get into pediatrics, you're going to talk more about newborn and infant infection. And here are some of the risk factors for neonatal sepsis. Low socioeconomic status, poor prenatal care, poor nutrition, if they're using substance abuse. I already talked about rupture of membranes, if the mom has a fever in labor, if there's signs of infection in the amniotic fluid or in the amniotic sac, which would be a very foul odor, a prolonged labor, premature labor, or a urinary tract infection. All of these are going to be risk factors for sepsis. And then nursing management is this baby's going to be admitted to the NICU. They're going to have antibiotic therapy. We're going to support whatever systems need to be supported, circulatory, respiratory, nutritional. Obviously, we're going to educate the parents and talk about early recognition of signs of sepsis. So even babies that are going home at 24 to 48 hours, we want to make sure these parents know what is normal behavior and what is not normal behavior so that we can catch that early. And then, of course, prevention. So that is it for our chapters 23 and 24. If you have any questions, you know where to reach me.